Hi there. My name is Hassan Sallam. I work for Alexandria University. I'm a professor in the Faculty of Medicine. And today I'm going to talk to you about the abnormal uterine bleeding. Now, what is abnormal uterine bleeding? Well, the term covers a broad spectrum. It describes irregularities in the menstrual cycle involving frequency, regularity, duration, and volume of blood flow, which is obviously outside of pregnancy. Now, how prevalent is abnormal uterine bleeding? Well, between 3 and 30% of women of childbearing age complain at a certain time of their life of abnormal uterine bleeding. Now, it depends, of course, on what study you're referring to. Some studies make the prevalence higher than other studies, of course. And some studies say that about 35 and others say about 55% of women in late childbearing age will have abnormal uterine bleeding. Abnormal uterine bleeding represents 5% of visits to general practitioners and 20% of visits to gynecologists, and up to 50% of patients do not seek medical advice. Now, before talking about abnormal uterine bleeding, we should really define what is normal menstruation. Now, again, there are no hard and fast rules. There is no universal definition. The frequency of normal menstruation is anything between 21 to 35 days. But the duration, again, some people would take it between 4 to 6 days, while others would take it between 2 to 7 days of bleeding. The quantity, again, from 50 to 160, although some people will tell you that from 25, less than 25 or more than 80 would be the abnormal quantity. And then with a mild discomfort that does not interfere with daily activities. Now, what is the mechanism of menstruation? Now, towards the end of the cycle, of the ovarian cycle, progesterone comes down. So there is withdrawal of progesterone in the premenstrual phase. And this stimulates the release of prostaglandin F2 alpha, which in turn leads to vasoconstriction of the spiral arterioles, and then there will be endometrial effusion of the functional layer, and then the functional layer will separate. If we look at the left side of this picture, we will find the myometrium. Above it, there is a basal layer which never separates. If it separates or if it is disturbed, further development of the endometrium will not happen. And in fact, the woman may have Asherman syndrome because, for example, the doctor has done excessive dilatation curettage of the endometrium, then he's affected the basal layer. But what separates really in normal menstruation is the functional layer. Now, this is again another diagram showing how the arcuate artery, which comes from the myometrium and then divides into a basal artery, which supplies the basal layer, and the spiral artery, which goes until the top of endometrium. And as you can see, there are also the endometrial glands, and the openings are on the surface of the endometrium. And again, another diagram showing the myometrium, then the basal layer, then the functional layer, which separates and then regenerates in the following cycle. So, what are the causes of abnormal uterine bleeding? Now, according to FRCOG, the Fédération Internationale de Gynaecologie, International Federation of Obstetrics and Gynaecology, which came up with this classification in 2011, we can divide them into organic causes and inorganic causes. And the organic causes, polyps, adenomyosis, leiomyoma, and malignancy, which can be summarized in the term PALM. And the inorganic causes, coagulopathy, ovarian dysfunction, endometrial causes, iatrogenic causes, and not yet classified, which we can summarize as COIN. So it's PALM, COIN, if you want to remember some term. And here it is, PALM, COIN. So let's start by the organic causes. Polyps, uterine polyps. Now, we know that polyps consist of various tissue components. They can be vascular, glandular, fibromuscular, or connective tissue. And they're usually benign, although some of them, minority, may turn malignant. and they may be confused with polypite-looking endometrium, which is a variant of the normal, which happens in endometrial hyperplasia. And then the FRCOG goes on to say that a subclassification is needed, which should include polyp size, location, number, morphology, and histology, because as you will see, there are some of these terms which have already been subclassified. Adenomyosis is another cause of abnormal uterine bleeding, and as you can see, it is of course the presence of endometrial glands inside the myometrium. So the prevalence again is between 5 to 70%, and the diagnosis should be based on ultrasound or magnetic resonance imaging. The ideal method is MRI, of course, but with ultrasound we can see the presence of heterotopic endometrial tissue in the myometrium and an enlarged myometrium. And again, FRCOG tells us that a subclassification is needed. Leiomyomas, or fibromyomas, or simply fibroids, as we know, they can be subserous, they can be intramural, or they can be submucous, as we can see from this diagram. So these leiomyomas, also called myomas, simply myomas, or fibroids, the prevalence is more in black women. So it can be up to 70% in Caucasians and 80% of African and in women of African descent, depending on what size you're talking about. They vary in size and location, of course, and as we said, they can be submucous, intramural, or subserous, or combined, of course. And many leiomyomas are asymptomatic. We should remember this. No symptoms, no treatment. They have very variable growth rates, and again, FRCOG has come up with a subclassification, as we will see now. So this is the subclassification system of FRCOG for leiomyomas. As you can see, 0 is pedunculated intracavitary submucous, and 1 is where less than 50% is intramural, and 2 is when more than 50% is intramural. So 0, 1, and 2 are submucous fibroids. Now the others, class 3, is when it contacts the endometrium and they are 100% intramural. We cannot see them by hysteroscopy, for example, but they are touching the endometrium. 4, they are intramural, not touching the endometrium or the serous outside of the uterus. Class 5, subserosal with more than 50% intramural, and 6, subserosal with less than 50% intramural. And 7 are the subserosal pedunculated. And 8 covers any other cervical, parasitic, any other fibroids which cannot be included under the previous 0 to 7 subgroups. And then we have the group called 2 to 5, which are at the same time submucous and subserosal. So they can be seen from inside the uterus, and they can also be seen from outside the uterus. Then the fourth cause of organic etiology of abnormal uterine bleeding is malignancy. And when we say malignancy, it can be, of course, the important one is endometrial cancer. Although other cancers can also cause abnormal uterine bleeding. So endometrial cancer, the age is adjusted incidence is 27 per 100,000 women. It's more common in white, obese, and diabetic women of low fertility or infertile women. The average age is about 60, but it's rare to happen in women less than 45 years of age, because as we know, they are hormone dependent, estrogen dependent, and they require a long period of unopposed estrogen secretion. And in postmenopausal women receiving hormone replacement therapy, the risk of cancer is approximately 6 to 0.7% if the endometrium is thick, more than 11 millimeters, and less than 2 in 1,000 if the endometrium is thin. So that's important to remember when we are talking about women who have postmenopausal bleeding. And these are the stages of endometrial cancer, as you probably know them. Stage 1, which is confined to this body of the uterus. Stage 1A, the endometrium, and Stage 1B, which has invaded the myometrium. Stage 2, which has gone to the cervix. And Stage 3, which has spread outside the body of the uterus, but still within the pelvis, with lymph nodes. For example, this would be Stage 3C, or at the vagina, which is B3B, or to the ovary, which will be 3A, and then Stage 4, which are distant metastases, either in the liver or the bladder or other places of the body. Because the second type of malignancy are the sarcomas of the uterus. They are extremely rare, 6 in 1 million, and the average age at diagnosis was 61 years of age. They tend to be aggressive because the 5-year survival rate is only 50% if the tumor is confined to the uterus. Because if you compare this to most other gynecological cancers, the 5-year survival rate will be about 90% if the tumor is confined to the original organ. They are highly curable when detected early, and uterine carcinosarcoma is a very rare type of cancer of the uterus, with features of both endometrial cancer and uterine sarcoma. So it is carcinosarcoma, involving the endometrium and also the myometrium, known also as mixed mesodermal tumor. And this is the classification, the clinical staging of sarcoma of the uterus. Stage 1, again, the tumor confined to the uterus, less than 5 centimeters and more than 5 centimeters, being it 1A and 1B. Stage 2, the tumor spreads to the pelvis, involving adnexa, so that will be 2A. If the tumor spreads to the extrauterine pelvic tissue, that will be 2B. Then Stage 3 will be when the tumor invades the abdominal tissues, so it invades one site, so it will be Stage 3A. More than one site, Stage 3B. And then if the metastases are in the pelvis or the lymph nodes and the para-aortic lymphatics, we will consider it 3C. And finally, distant metastasis will form Stage 4. Metastasis invading bladder or rectum will be 4A, and then distant metastasis will be 4B. And the third cancer which can give us abnormal uterine bleeding is, of course, cervical cancer. And as we know, it starts in the cervix but can spread to further. And cervical cancer, the incidence is 13.1 per 100,000 women. More than 500,000 women every year. For example, in 2018, there were about 500,000 women all over the world affected with cancer of the cervix. It's more often diagnosed between ages 35 and 44. It is the fourth most common cancer of women and the eighth most common cancer overall. And 70%, as we know, are caused by sexually acquired infection with two types of human papillomavirus, type 16 and 18. And the 5-year survival is 71% for white women and 58% for black women. And it can be detected early by cervical smear screening. And of course, it can be totally avoided by giving a vaccine. These numbers, of course, are based on one of the studies, and you will have different numbers according to the study you are referring to. Another cause of abnormal uterine bleeding, which should be included under the M of PALM, is endometrial hyperplasia, because endometrial hyperplasia, if left without management or without treatment, will lead to endometrial cancer, malignancy. So the prevalence is 133 to 208 per 100,000 women, depending on the study you're looking at. It results from high levels of estrogen, unopposed estrogen, combined with insufficient levels of progesterone, as I said, unopposed estrogen, like cases of polycystic ovary syndrome, women who do not have regular ovulations, granulosa cell tumor, hormone replacement therapy in the menopause, etc. And they are classified by WHO into 4 categories: simple hyperplasia without atypia, complex hyperplasia without atypia, simple atypical hyperplasia, and complex atypical hyperplasia. So the first two without atypia, the following two are with atypia. And finally, it is an important risk factor for the development of endometrial cancer, as I was just saying. The second group of causes of abnormal uterine bleeding are the COIN group, referring to coagulation, ovulatory dysfunction, endometrial causes, iatrogenic causes, and not yet classified. And these are the inorganic causes because you cannot find an organic lesion. So the first cause then is coagulopathy. So if a woman has a problem in her coagulation system, then she can have abnormal uterine bleeding, and of course, the coagulation cascade is quite complex as we know it. So at any stage of this cascade, we can have a problem, and it needs proper management by hematology expert. But about 13% of women with abnormal uterine bleeding will have systemic hemostasis disorders, most often von Willebrand's disease. It is not clear how often these abnormalities cause or contribute to the genesis of abnormal uterine bleeding. Few clinicians, but we know that few clinicians consider them during their differential diagnosis, but they should always be in our mind when we examine a patient without any organic lesion. And we have to remember that some women are using blood thinners or any sort of anticoagulants for different problems, including cardiovascular problems, and then this can lead to abnormal uterine bleeding. Ovulatory dysfunction is the second cause of this COIN group, and we remind ourselves of the different interplay of the different hormones and how FSH starts at the beginning of the cycle, stimulating the follicles which produce the estradiol, and then the estradiol will trigger the LH, then leading to progesterone, ovulation and progesterone release, which reaches its acme on the day 21, or the mid-luteal phase anyway, and then comes down. So ovulatory dysfunction is therefore a cause of abnormal uterine bleeding, and these bleeds can be extremely light or infrequent, and can be episodes of unpredictable, and sometimes they can be extreme hemorrhagia. The amount of blood would be excessive. They may be due to decreased production of progesterone from the corpus luteum, or irregular production of progesterone in premenopausal women. And again, they are due to endocrinopathies like polycystic ovary syndrome, hypothyroidism, hyperprolactinemia, mental stress, all these causes which lead to abnormal ovulations or anovulations or irregular ovulations, including obesity, anorexia, weight loss, extreme exercise, and all these causes which can lead to disturbances of ovulation. Endometrial causes again can lead to abnormal uterine bleeding, and we remind ourselves again of the follicular phase of the endometrium and the luteal phase, and how in the first part of the cycle we have the endometrium still building up with the glands are straight and they are lined by cubical endothelium, while after ovulation the glands are going to become more convoluted and lined by columnar epithelium, and after day 21 they will start secreting the glycogen and they will be a secretory endometrium. Abnormal uterine bleeding can also be due to a problem in the disorder in the mechanism regulating the local endometrium hemostasis, like a deficiency in the production of vasoconstrictors like the endothelin 1 and prostaglandin F2 alpha, or an increase in the local production of vasodilators like prostaglandin E2 or prostacyclin, which is prostaglandin I2, or to accelerate endometrial clot lysis due to excessive production of plasminogen activator, or a deficiency of the endometrium repair mechanism due to inflammation of the endometrium, abnormal vasculogenesis, and this diagnosis should only be reached by exclusion. And finally, the iatrogenic causes of abnormal uterine bleeding. Iatrogenic, iatros in Greek, means a doctor, so there are problems produced by the doctor himself. And this can be due to the fact that the doctor has given pharmacological agents like steroids, including estrogens, progestins, androgens, oral contraceptives, and so on, anticonvulsants of antibiotics, like rifampicin and grisifulvine, because particularly if given with other steroids, because they will affect the absorption of the steroids. And maybe the doctor has given agents that interfere with dopamine metabolism, such as tricyclic antidepressants and phenothiazides, which will affect normal regular ovulation. And of course, anticoagulants, as we said, like warfarin, heparin, or low molecular weight heparin. Or the doctor may have inserted an intrauterine device, and we know that between 20 to 25% of women experience unexpected bleeding or bleeding from vagina within the first 3 to 6 months of using any device, including the levonorgestrel releasing intrauterine system. And finally, we have the unclassified group, when we cannot put the cause in any of the previous mentioned groups, so we call them non-classified. And this is, so non-classified like what? These are the poorly defined, poorly examined entities like chronic endometritis, arteriovenous malformations, myometrial enlargement, and other disorders, of course, not yet identified, which would be defined only by biochemical or molecular biology tests. So FIG always takes care of the future developments. Maybe anything will be discovered in the future. So how do we manage the case of abnormal uterine bleeding? It starts, of course, by taking a good history, then doing a proper examination, a general examination, abdominal examination, a vaginal examination, then asking for the investigations. These can be an ultrasound, 2-dimensional or 3 or 4-dimension, taking endometrial biopsy, doing laboratory investigations. Sometimes we have to resort to a hysteroscopy or an MRI. Sometimes we need to do hysteroscopy or laparoscopy. And finally, after reaching a diagnosis, we will do our treatment accordingly. It could be medical treatment, surgical treatment, or other forms of treatment that we are going to discuss. A good history, of course, starts by asking about the duration of the bleeding, the amount, having a good obstetric history, gynecological history, asking about past and present illnesses, any current drugs, including anticoagulants, any intrauterine devices. As they say, taking a good history is winning half the battle. And what can help here is to have a menstrual pictogram to help the patient determine exactly the amount of bleeding that she's having. And then when we do the examination, abdominal examination, as we said, general abdominal examination, but then we do the vaginal examination, or we should call it a bimanual examination, because we always have to use both our hands to compress the uterus between both our hands to feel the uterus properly. Although vaginal ultrasound today can help us a lot. And here is vaginal ultrasound, and which can give us a better idea even than the bimanual examination. And during the examination, the ultrasound, we may discover that there is a fibroid, or during the examination, we discover there is a fibroid here. With this abdominal ultrasound, there is a fibroid, we can see here. And this is the vaginal ultrasound, again showing a fibroid. On the right side you have the uterus, on the left side you have the fibroid. Again, we may resort to sonohysterography, which means that we inject saline or similar radio opaque fluid inside the uterus, and then doing ultrasound, and in which case, like in this case, we can discover that there are small uterine polyps, as you can see here. Ultrasound, 4D ultrasound, 4-dimensional ultrasound, can also help us in giving us a better picture. As you can see here, there is a fibroid which is encroaching a little bit on the right side on the uterus. And again here, there is, with the same 4D ultrasound, we can see a polyp inside the uterus. So it's or a submucous fibroid or a polyp, which can be clearly seen by 4D ultrasound. Using ultrasound also can help us in it gives us a good idea about the blood supply of the area. If we have an abnormal tissues that we are suspecting of being malignant, for example, we can do a Doppler study, and the power Doppler will tell us the amount of vascularization that we have in this area. Of course, during ultrasound, it is very important in patients with abdominal uterine bleeding to look at the endometrial thickness because it is thick. This means endometrial hyperplasia and which can in turn lead to malignancy. And again, as I said, a Doppler study of the endometrium and or the myometrium can tell us whether even this fibroid can be a fibroid or there may be some sarcomatous changes in this fibroid. Then we sometimes need to do an endometrial biopsy. So using a PIPEL, for example, there is no need to do a whole dilatation to take a simple biopsy. We now have these plastic PIPELs where we can take an endometrial biopsy. But if we are suspecting something, we can take the biopsy hysteroscopically directed biopsy, endometrial biopsy, as you can see on the right lower part of the slide. Then we ask for our laboratory analysis. It's important to do a complete blood picture to see exactly how the hemoglobin is, then an endocrine assessment, and then finally a coagulation profile. So here is the blood count, and the important thing, as I said, is the hemoglobin. According to what reference value you have, if it is less than 11 grams, we would consider it anemia, but again, it will tell us how the patient is, the amount of blood the patient is losing, and if it is affecting her general condition. Then we should do a hormonal profile to see if we are suspecting that the patient has an endocrine reason for her abdominal uterine bleeding. So measurement of plasma progesterone in the mid-luteal phase can help us, and then we can also measure follicular phase FSH, prolactin, serum TSH, and T4, and if necessary T3 also, and then plasma testosterone and androstenedione if necessary. And as I said, coagulation profile is also important, particularly the responding time and the APTT test, because these are going to tell us essentially if there is a coagulation problem, in which case we better to refer the patient to a hematologist who is going to sort out her problem. Sometimes we need to do a hysterosalpingography, particularly if we suspect there is a polyp there, although many of these cases can be seen by 4D ultrasound and eventually by hysteroscopy. So adenomyosis, as I said, is the best way of diagnosis. Diagnosing and adenomyosis is the MRI, as you can see on the right side, although on the left side we can see above a 2D ultrasound and below a 4D ultrasound with the disappearance of the demarcation line between the endometrium and the myometrium, which is again another sign of adenomyosis. And finally, we may need to do hysteroscopy and look inside the uterus to see if there is a lesion there, and maybe also take a biopsy. So this is hysteroscopy, and on the left side we have a normal endometrium, and in the middle we have a polyp, and on the right side we have synecdoche, which are not, in this particular case, they are not going to produce abdominal uterine bleeding, but this is something that we can see by hysteroscopy, particularly in patients who are infertile. Laparoscopy again can help us. For example, in this case, we can see that this fibroid, that there is a posterior fibroid, and it is encroaching on the cervix, so that before doing a laparotomy, we know whether it will be possible to remove the fibroid or not, or do we have to do a total hysterectomy, for example. So enough for the diagnosis. We have done our investigations. We know we have reached a preliminary diagnosis or a definitive diagnosis. So what do we do as a treatment? Of course, there's always the general treatment of the anemia, and by giving hemostatic agents and giving iron supplements, for example. And then there will be the specific treatment of the cause, if it will be a medical treatment or a surgical treatment of other sorts of treatment, as we said. So the treatment of anemia will be in form of iron oral iron supplementation or parental iron supplementation if the anemia is severe or the patient cannot take oral iron for any reason. Sometimes we can even resort to blood transfusion if the anemia is very severe, or to packed red blood cells administration. And then giving again hemostatic agents to stop this bleeding, for example the tranexamic acid or non-steroidal anti-inflammatory drugs to try and stop as antiprostaglandins to try and stop the bleeding or diminish the amount of bleeding anyway. So what are the medical treatment? What is the medical treatment for abdominal uterine bleeding? Essentially, the first line of treatment is progesterone, either on its own or with in the form of oral contraceptives or even devices containing progesterone. So as I say here, number one, progesterone and progestins. Progestins are compounds which have the same effect as progesterone. And progesterone itself, if given by mouth, it will be destroyed. So drug companies have given us micronized progesterone, for example, but what is more gives us a better result in these cases are the progestins, the 19-nortestosterone derivatives, which of course we cannot use them in pregnancy because they may lead to masculinization of a female fetus. But in this particular case of abdominal uterine bleeding, we can use these oral progestins. We can also give progesterone by intramuscular injection, although if we give progesterone itself, we have to give it every day, so we give long-acting preparations. And again, as I said, we can use intrauterine devices, as we will see now. We can also give progesterone in the form of oral contraceptives. They are available. They are cheaper in many countries. And finally, we can then resort to the long-acting Gnrh agonists. So these are the lines of medical treatment. So this is progesterone, a small molecule of 314 Daltons molecular weight. But the problem, as I said, is that it is destroyed in the upper gastrointestinal tract and it has a short duration. Therefore, the drug companies have come up with progestins. So progestins are compounds which have the same action as progesterone. They can come originally from 21 carbon progestins, the so-called progestogens, and also called pregnenes like medroxyprogesterone acetate, megestrol acetate, and cyproterone acetate. And some of them are coming from 19-nortestosterone, the estranes, which contain 18 carbon atoms, the gonanes, 17 carbon atoms. Most of these progestins are used in oral contraceptive preparations, like norethindrone, norethindrone acetate, ethinodiol diacetate, estrenol, and norethinodrel. And then we have also the norgestrel, the levonorgestrel, norgestimate, desogestrel, and gestodine we all know them from our oral contraceptive preparations. And finally, we have the drospirenone, which is coming from spironolactone. Theoretically, any of these compounds can be used because it is a progestin. However, most of the cases we use medroxyprogesterone acetate. It is a simple treatment, can be given by mouth twice a day from day 15 or 25, although some people give it from day 5 to 25 for this unopposed estrogen, because as we said, many of these patients who have no organic lesion have unopposed estrogen, and in this case we want to give them this progesterone either for the second part of the cycle from day 15 to day 25, or from day 5 to day 25 of the cycle. Another compound which has been recently introduced in the market is dydrogesterone. It is very similar to progesterone and can be used orally, and therefore again can be given from day 5 to 25, from day 15 to 25, as we said before. And then, as said, we can have our long-acting preparations. How do the drug companies prolong the action of progesterone? By combining it with fatty acid, stearic acid, oleic acid, but in this particular case, caproic acid was the best compound to be used. So we have this preparation, which is a 17-alpha-hydroxy progesterone caproate. At position 17, the caproic acid is attached, and as you can see here, we have this 17-alpha-hydroxyprogesterone caproate. Another method of administering progesterone or progestin is to give it by an intrauterine device containing progestin. In this case, it is levonorgestrel, as you probably know. The other way of doing it is to give oral contraceptives. We know that oral contraceptives essentially are a progesterone compound with sometimes a little bit of estradiol, either in the form of estradiol, ethinyl estradiol, or estrianyl estradiol 3-methyl ether, which is also called mestranol. So anyway, oral contraceptives. Another method is to give long-acting GnRH agonist. We know the GnRH, which is in the upper panel. This is the normal GnRH produced by the hypothalamus to stimulate the pituitary. So the idea in this case is that we are giving a compound which is similar to GnRH, but which has an opposite action to GnRH. So it will stop the effect of GnRH. Therefore, diminishing the amount of FSH which is produced by the pituitary, and therefore diminishing the amount of estrogen which is produced by the ovary, which is our problem in these patients with unopposed estrogen. There are many GnRH agonists, leuprolin, goserelin, triptorelin, and buserelin. There are many of them. Some of them are given by an intranasal administration, but in this particular case, it is always good to give long-acting preparation, which is given every month and sometimes even every 3 months. The other form of treatment, of course, is the surgical management of abnormal uterine bleeding. And in this case, we have to ask ourselves whether the woman has completed her family, because if she has completed her family, there are methods which we can use, surgical methods which we can use, for example, total abdominal hysterectomy or sometimes endometrial ablation, or she still wants to have more children. Because the surgical options we have, we can do DNC, dilatation and curettage. If there is a polyp, we can remove the polyp. If there is a fibroid, we can remove the fibroid by doing myomectomy. And as I said, if the woman has completed her family, then we would do a hysterectomy. And how do we do these things? We can do this. Dilatation and curettage is known, but hysteroscopy we can do. We remove our polyp, for example, by hysteroscopy. We don't have to do laparotomy. We can sometimes remove the fibroids by laparoscopy or by robotic surgery. And if these methods cannot be used, for example, because the fibroid is too big, then we will resort to laparotomy. And finally, we also have the vaginal surgery if a fibroid or a polyp is accessible from the vagina. So dilatation and curettage is a minor operation. It requires minimum seals. It allows us also to take a biopsy, so we do the DNC and then we take a sample of the endometrium and send it to a laboratory to make sure that there are no malignant changes, for example. But we have to remember that this is a temporary effect, and we have to remember always that there is a risk of perforation, particularly if this bleeding is due to a malignancy, because malignancy makes tissues friable, and therefore the doctor will be doing the DNC, doing the curettage, as we call an endless curettage, which ends up by doing a perforation. Polypectomy can be removed by DNC, but of course it is always better to do it under vision by doing hysteroscopy. So we do a hysteroscopic polypectomy, as we can see on the right side. Myomectomy, of course, is when we have a fibroid and the patient wants to have more children, so we are not going to remove the uterus, we only remove the fibroid. And this can be done by open surgery, a laparotomy, or can be done by laparoscopy, as you can see in the left picture here, or can even be done by robotic surgery, which is a more advanced and more sophisticated method of laparoscopy. And here is the robotic surgery. Robotic surgery, all the equipment is attached to inserted in the body of the woman, and also the scope is inserted in the body of the woman. The woman has to be very does not have to have good anesthesia, so she does not move. And then the doctor himself is sitting on the left side. As you can see, he is sitting on the console and manipulating the instruments through his console, while the patient had with her the assistant or the anesthetist and the nurse, as you can see. If, of course, the patient has completed a family, then sometimes we need to do hysterectomy. And if we remove the uterus without the cervix, this is called subtotal hysterectomy. But if we remove the uterus with the cervix, this is total hysterectomy. And if we are going to remove the tubes and the fallopian tubes and the ovaries, now this will be a total hysterectomy with bilateral salpingo-oophorectomy. Of course, we can do a total hysterectomy with unilateral salpingo-oophorectomy, or we can do a subtotal hysterectomy with unilateral salpingo-oophorectomy. So the variants are there. Because hysterectomy can also be done by laparoscopy. As you can see here, the whole procedure can be done, and then this big uterus that you are going to remove can be removed from the vagina, in which case we call it laparoscopically assisted vaginal hysterectomy. So we use the laparoscope to cut the uterus from its surrounding organs and leave it free inside the abdomen, and then remove it from the vagina. So it is really a vaginal hysterectomy, laparoscopic assisted vaginal hysterectomy. On the other hand, it can be done totally abdominally without opening the vagina, and then in which case this uterus, which has been separated from everything around it, is going to be removed either by enlarging the opening, or more commonly by doing morcellation, which means a tube which contains machine that will cut the fibroid into shred the fibroid to small pieces and aspirate it through a tube which is about 1 centimeter in diameter or 12 millimeters in diameter. The other way, of course, of removing the uterus is to do vaginal hysterectomy, particularly if the uterus has got some degree of prolapse. As you can see on the right side, the uterus is already prolapsed, and it will be even easier to bring it down from the vagina. Because there are other treatment modalities, like endometrial resection, endometrial ablation, uterine artery embolization, and MRI-guided ultrasound-focused myolysis. Endometrial resection, for example, we use the resectoscope, which is something attached to the hysteroscope. As you can see, we do hysteroscopy, and the hysteroscope has a side channel through which we insert this ball, for example, and this ball goes up and down to coagulate the endometrium. Or, as we can see in the lower panel, we may have again a rolling ball, but on the right side we have a resectoscope which resects the endometrium, resects one by one, as you can see, in form of furrows. As you can see here, we go the front, the anterior wall, then the posterior wall, then the side walls, and then the fundals, the fundal areas right and left, so that we can remove the endometrium altogether. This, of course, leads to obliteration of the uterine cavity, and of course the woman will stop having any periods after that. Although if we leave some endometrium, she will have some regular cycles, or some cycles anyway, which are going to be light. However, the problem with this technique is that if the woman develops cancer, the bleeding is not going to be obvious from the beginning, because one of the advantages of endometrial cancer over other cancers is that it gives you very early signs. The woman comes with heavy bleeding, you examine, you find that she has endometrial cancer. as opposed to ovarian cancer, which is a silent menace. You discover ovarian cancer usually at advanced stages. So when we do endometrial resection, sometimes if the woman develops cancer, then it will hide the symptoms for a later stage. So when she presents, she may already be having an advanced stage of endometrial cancer. Endometrial ablation can also be done by laser. It has been described. However, the laser is very thin, so you take a long time to ablate the endometrium with the laser. This is why it's not a very commonly used method. Endometrial ablation can also be done by hydrotherapy, a balloon which is placed inside the uterus and then inflated, and then in the balloon goes a fluid which is heated by a control box, computerized, and then according to the time and the surface area that you want to coagulate. So you do this endometrial ablation by hydrotherapy. Endometrial ablation can also be done by microwaves. Again, we put this probe inside, and it is regulated by a computer which calculates the amount of radio frequency or microwave frequency that you are going to use, and depending on the surface area that you want to ablate, and so on. Another method is by radio frequency. Now, this kind of a probe which goes inside the uterus, and then it goes like a fan to spread along the whole of the endometrium, again by radio frequency. As you can see, you can have endometrial ablation. So all these are new modalities which are computerized, and they are actually quite simple, and they are minimally invasive by nature. Another method is uterine artery embolization. So you put these small polyvinyl particles in the uterine artery. This, of course, can be done by a catheter, which is introduced usually from the femoral artery. The people who do it are usually our colleagues in interventional radiography. As you can see, the catheter is introduced and then guided through the internal iliac anterior branch, and then the uterine artery, and then the particles are deposited. It is important to deposit them in the right place in order not to produce any blockage of any other artery, which may lead to disturbance of circulation in the nearby organs or sometimes gangrene. Another modality is the MRI guided ultrasound focused myolysis. This is ultrasound, high frequency ultrasound. It is not the ultrasound we use for diagnosis. It is the ultrasound we use for destroying objects, like our colleagues in urology use this technique to treat the stones. So they destroy the stones with this high frequency ultrasound. We know that ultrasound are mechanical waves, really. So we use the ultrasound frequency for our diagnosis, but you can increase the frequency using these machines so that you can actually destroy a stone. And therefore, it can be used to do lysis of the fibroid. Then, as you can see, the woman is lying on her front, the transducer comes from below, and it has to be properly focused by MRI, otherwise it will destroy neighboring organs. So what are the advantages and disadvantages of minimal invasive therapy? It is a minimal invasive therapy, as we said, endometrial ablation, endometrial resection, and all these new modalities. The first thing is that they're expensive, particularly the focused ultrasound myolysis is very expensive. It requires training, although minimal training. There is always the risk of perforation. For example, if we're doing endometrial resection with hysteroscopy, it needs a lot of training, and then one may lead to perforation, particularly if we are trying to working around the area of the cornea of the uterus. Then there are risk of systemic complications. For example, as we said in uterine artery embolization, the embolus may affect other neighboring organs if we put the particles, the pellets in a different blood vessel. There is always the risk of recurrence, and there is a risk of malignancy masking, as we said. We do resection and the uterus is going to have adhesions. Then if the woman develops malignancy, then the symptoms are going to be delayed, and then she will present to us in an advanced stage of malignancy. So in short, the treatment should be individualized according to the patient. How old is she? Does she want more children or not? Is she obese? Does she suffer from other systemic conditions? Is she diabetic? She has hypertension? How much is the anemia present, and so on? Is there a suspicion of malignancy, and so on? So because one size fits all fits no one, actually. And with this, I come to the end of this presentation, and I'd like to thank you very much for your attention.